So now we are going, after such a nice talk, to Dr. Jatin Saha, I am inviting, who will be speaking on managing poor responder.
Now let's discuss probably what is one of the most important topics if you are to run a
Alina.
successful IVF practice. And I'm sure all of you agree that almost 50% of your patients are in some form poor responders when it comes to their IVF treatment. To put things into perspective, let's look at this wonderful study which correlates endometrial thickness with final clinical live birth rates. And you will see even at a thin endometrium of 5 to 6 mm, you still have live birth rates in the range of 20%. So what does this show? This exactly proves Venetius's point that if you consider a pregnancy as 100%, the contribution of the sperm is probably 10%, the endometrium is 10%, but the oocyte contributes 80% of a final pregnancy unit. So what is it, the most important component for you is to get a competent oocyte so that the embryologist gets a top quality embryo which you can then use to get a take home baby. So how do we classify? Of course, I'm not going to go into too much detail because we are strict on time, but you're all familiar. Poseidon 1 and 2, young and old patients who have an unexpected poor response despite having a normal ovarian reserve, and Poseidons 3 and 4, where you expect a poor response because they start off with a poor ovarian reserve. So how do you go about managing 1 and 2? Now remember, these are patients, most of them are iatrogenic poor responders, means you did something wrong or you did not diagnose things properly, which is why she just gave you 3 oocytes when you were expecting about 15. And the commonest reasons here are, number 1, low gonadotropin starting dose. We are in the times of the agonist trigger, we are in the times of the antagonist, we are in the times of vitrification. What are you scared of? Why are you underdosing a patient? Your minimum starting doses need to be adequate to make sure that you don't get a Poseidon 1 because of a low dose. The second commonest mistake everyone makes, especially in an antagonist cycle, is not giving pre-treatment. Patient walks in on day 2 evening and you don't want to waste the cycle and you start your stimulation. One dominant follicle races ahead, the others are lagging behind, you end up with an asynchronous cohort, and then you say, oh, she gave me only 2 metaphase 2s. The third, the presence of genetic polymorphisms. Of course, this is the third important reason, and we know 10 to 15% of Poseidons 1 and 2 will be carriers of genetic polymorphisms as the reason of their poor response. And the fourth, again often neglected and taken for granted, is what trigger did you use finally for that patient. So does every extra oocyte count? Why do I keep saying oocyte, oocyte, oocyte? Because with every extra oocyte that you get, there will be a tremendous increase in the live birth rate. You can see with 1 oocyte, you are at 4%. With 3 oocytes, you are almost at 12% live birth rate. So don't just take it very lightly. Oh, I had 6 follicles, I got 3 M2s. You did not do a good job. 6 follicles, you should have got 6 oocytes, at least 5 metaphase 2s to do proper justice to that patient. Do we overlook, are there any other predictive factors? And this wonderful study, very recent study from this month from Carlo Alvighi, clearly shows that on a day 2 scan, if you see fewer smaller size antral follicles, she is likely to be a Poseidon 1 and 2, and you'd rather step up your expected dose by 75 or maybe even add LH for this patient right from the beginning. So the take home message is your minimum starting dose should not be 150 even for your thin, lean PCOS patient. You have nothing to be scared of. Even if she responds with 50 follicles, you just have to give the agonist trigger and do a freeze-all rather than give her 112.5 and then end up with just 2 or 3 metaphase 2s. So please shed these fears, be fearless. Start with 225. A lot of Indian women need 300. A lot of them need even 450 as a starting dose. So use your combination of age, AMH, AFC, associated PCOS, endometriosis, whatever it is, her past response if she's done cycles in the past, and then decide what should be the starting dose for this patient. How much do you increase? If she comes with a previous cycle done somewhere else where 225 was given and she had just 4 oocytes, you can easily step up to 300 or 375. You don't have to go to 600, and you can expect a much higher number of oocytes. Synchrony, again, the most neglected and very important, but here you need pre-treatment strategies. You cannot jump into stimulation on day 2 just because you think she'll go away somewhere else or you don't want to waste that month. Remember that the most important thing is to avoid follicular dominance in a short antagonist cycle. And why do I say short antagonist cycle? That exactly proves the point that the long agonist cycle is the best for getting synchrony. all those of you who have done long protocols, about 15-20 years ago when we started practice, 30 years ago for me, we only had the long agonist protocol, and we never had this problem of dominance. It would always be a beautiful cohort because you have suppressed her, you start with HMG, and she will have all follicles in the same diameter range. So this is very important, that we need to rejuvenate and not give up the long agonist protocol. And the agonist, you can see, even affects the oocytes with cytoplasmic abnormalities. Means not only does it give you a uniform cohort, but it's giving you better oocytes, better zygotes, and higher clinical pregnancy rates. This is because you completely suppress LH and progesterone levels throughout the follicular phase, and therefore you get, if you have 10 follicles, you get 10 oocytes, and you probably will get always your 9 metaphase 2 oocytes. So that is the advantage here. We gave it up because of OHSS in high responders, but remember, isn't that what you want in a poor responder? We said no, in a high responder with long agonist, you get too many oocytes, too much OHSS, but here you want more oocytes. So why are you giving up a protocol which is a gold standard and such a beautiful protocol for most poor responders? Very interesting study that it's not only direct effect on oocytes and embryos, but even the endometrium is much better in a long agonist protocol. So if you have to do a fresh embryo transfer, you're going to get very good pregnancy rates. And you know now that we are moving back to doing more and more fresh transfers. Please don't adopt freeze-all for all. There are genuine concerns of PIH and macrosomia with your HRT, prepared endometrium, and FET cycles. So again, you see this study here, again showing the agonist does much better. Clinical pregnancy rates up from 32 to almost 58% just with the use of the agonist in a poor responder. Other important point, you keep worrying about, oh, what if the LH is high on day 2 and so on. In these days of random start, luteal phase stimulation, how does it even matter? When you're doing a luteal phase stimulation, isn't your progesterone and LH high? And still you get good eggs, you get good embryos. So why are you worried? You need to give LH right from the beginning if you don't want to do expensive tests on polymorphisms for all your patients. So as a general rule, for all normal responders, I like to add 75 of HPHMG from the first day along with the REC FSH. And for all poor responders, we love to add 150 or even 300 of just HMG or 450 right from the beginning of stimulation. So of course, all elderly women will need LH. All hypo responders where there are stagnant follicles will need LH. All patients with hypo, please start with 300 of HMG. She is not going to respond to 150 or 225 or REC FSH alone. Hypo, you have to start with 300 FSH and 300 LH. She will produce 20-25 follicles. You cannot give her the antagonist. You need not give the antagonist because she doesn't have any endogenous LH to release. You cannot use the agonist trigger for the same reason. You have to give an HCG trigger, freeze all. Give her your Caberlin and Letrozole. She settles down in 5 days. Nothing happens, and they have almost a 70 to 80% pregnancy rate in the first FET transfer. So please don't get scared. 300 of HMG is your minimum starting dose for hypogonadotropic hypogonadism patients. And poor responders, of course, we have to give LH right from the beginning. Why you need to add LH? And this is a wonderful new study, 2024, again showing long-acting corifoliatropin alpha alone versus corifoliatropin alpha along with 150 IU of HPHMG from the beginning of stimulation. And as expected, you can see estradiol levels are much better when you add HPHMG. You have much higher fertilization rates and you get more good quality blastocysts for transfer. So there is enough evidence now to show that some amount of LH. And why HPHMG? Because it has HCG driven LH activity which tends to accumulate, unlike just giving native LH. So as I told you earlier, you get more blastocysts, and that is exactly what you want, especially in the poor responders. The other forms of pretreatment, if you still feel no, I don't want to do down regulation, I am scared of OHSS, then you have, of course, luteal estradiol valerate. You can use norethisterone, or again, what is really working well is just give the antagonist. Like you want to come to Bhubaneswar for ISAR and you just need 3 days of scheduling. Give her antagonist on days 2, 3 and 4. Dual effect and advantage. One is you postpone the pickup date by 3 days. and you ensure follicular synchrony. The minute you give antagonist on day 2, 3, 4, then begin your stimulation from day 5, and then add back your antagonist when you get your lead follicle of 14 mm is the way to go, and the easiest to do if you don't want to give luteal estradiol or norethisterones, and definitely not oral contraceptive pills for these patients. And you can see from 9 it went up to 13 oocytes. I told you every additional oocyte you get is of benefit for that patient. Polymorphisms, I already said, if you don't want to do testing, if you add LH from the beginning, a lot of your Poseidons 1 and 2 will disappear, and you will not face that problem anymore, especially in patients young with normal AMH where you want 10-15 oocytes to come. 3 and 4, of course, we know, don't panic. Now remember, 3 and 4 have a low reserve, especially 4 are elderly. You need to give 2 to 3 months of pre-treatment with whatever is your favorite molecule, whether it is DHEA, whether it is ubiquinol, resveratrol, melatonin, vitamin D, all this. Don't panic that, oh, in 2 months your AMH may become even further down, and zero. Beautiful study here showing even if you delay treatment by 6 months, there is no change in outcomes or no sudden drops or disastrous drops in the AMH level. So please make sure that adequate pre-treatment is given. I have seen 2 weeks of coenzyme Q, stimulation starts. 5 days of testosterone, stimulation starts. No, we don't have time. We don't want to waste the month. You need to give them 60 to 90 days adequate pre-treatment. Now again here the agonist protocol, beautiful study. Poseidon 3, if you notice, the young patients, which is our biggest chunk, young patients with a low ovarian reserve, the agonist protocol gives you live birth rates of almost 30%, as against with the antagonist you get just 16.7%. So this is a huge study and huge number of patients in all the arms, and you can see again they have proven the fact that the agonist needs to be rejuvenated, and your first choice protocol for Poseidon 3 group of patients. How high to go with doses? Of course, you don't need to go too high. You can't flog a dead horse back to life. So remember, 300 is usually adequate for Poseidons 3 and 4 as the upper side. Sometimes 450 also, maybe more of LH and more of HMG than just giving 300 or 225. And you can see no matter how high you go, your final outcome is the same. Trigger, of course, many a times you have 10 follicles, you get only 5 oocytes. You had 6 oocytes, you got only 2 M2s. Again, the trigger is very important, and remember, the agonist trigger is the more physiological and superior trigger to HCG. For years, we have all been thinking that HCG is the best and the strongest. It's not true. The agonist gives you a perfect, not only simulates the LH peak, but also gives you a FSH rise, which is important for the final meiotic maturation of the oocyte. And that is why, especially in poor responders, where you want a complete conversion to metaphase 2, and this is a study which showed, you can see the blue line is agonist trigger derived embryos, the red line is HCG derived embryos. Clearly the cumulative live birth rates are better. And in poor responders, the dual trigger, that is HCG 6500 with triptorelin, and you will see a huge improvement in all the outcomes, especially the live birth rate, and almost half the miscarriage rate that you get in the control group. If you really want to fine tune it, then remember agonist at 40 hours and HCG at 34 hours prior to OPU is ideal and gives you the best meiotic conversion to maximum metaphase 2 oocytes. Then all of us went really hyper about dual stimulation. It's the new thing and it's the best thing for the poor responders. We thought we should exploit every wave of follicular recruitment in a menstrual cycle. We had papers published that luteal phase embryos are better, you have higher pregnancy rate, obstetric outcomes are as good with FPS as with LPS derived embryos. You can see this huge study from 2020. But what was the problem with this? The problem is that, are we really comparing follicular phase with luteal phase with what we were doing? We were doing follicular phase, we were giving an agonist trigger, we were then doing luteal phase, and again giving an agonist or HCG trigger. Now, when you give an agonist trigger, you have a very short luteal phase of just 2 to 3 days. It's not even a week. Patients menstruate within 3 or 4 days of the egg retrieval. Then how on earth were we calling it a luteal phase stimulation? You are again doing a second follicular phase stimulation, and that was the biggest drawback of conventional dual stimulation. Plus, because of the follicular followed by luteal, we could never do fresh transfers. We had to do freeze-all, and I told you now the trend is to not do too much of freezing because of a genuine concern of the large baby syndrome and PIH. So this is the correct way to do dual stimulation. You begin stimulation in the actual luteal phase. You give her the gonadotropins, add the antagonist, give your agonist trigger, let her menstruate, Now do a conventional follicular phase stimulation with an HCG trigger, and if you have a good endometrium, do a fresh embryo transfer using whichever embryos were of better quality, whether they were of the luteal phase, frozen ones, or the fresh ones in the follicular phase, and you will expect a much better pregnancy rate, and you have done a true luteal phase stimulation and exploited that follicular wave of recruitment there. Laboratory essentials, again, just because you get 2 oocytes doesn't mean you have to do ICSI. Just because the woman is 38 doesn't mean you have to do ICSI. There is absolutely no evidence that ICSI is better for poor responders, and not one. Just see the number of papers we have that IVF is in fact better even if you have fewer oocytes or you are dealing with an elderly woman. You can see here 1 oocyte, 3 oocytes, 4 oocytes, IVF ICSI give you the same outcomes, no difference and no justification with unnecessary ICSI. And the biggest reason for not doing unnecessary ICSI is this publication from John Hopkins. They followed up 2 lakh infants born out of ICSI IVF, and they showed when you do ICSI, in the absence of a male factor, your incidence of anomalies, for example, blastogenesis, becomes 1.5. So there is a 50% increase in the anomalies. So if it was originally 2%, 2 in 100, you have made it 3 in 100 by doing an unnecessary ICSI procedure for this patient. So please tell your embryologist to go by strict parameters to decide whether to do IVF or to ICSI. So we have clear conclusions from this huge study of 2 lakh infants that please don't do ICSI when not indicated. Very important, I'm sure a lot of you might be following it, for all your Poseidon 4s, please do artificial oocyte activation for every patient. It's very easy to do, and all you have to do is, of course, the minute ICSI is done, you put it in equilibrated media for oocyte calcium activation for 15 minutes, then wash off the medium and put it into your regular culture, and you will see you will have a 3-fold increase in the possibility of more than 1 top quality embryo, and a 2-fold increase in the possibility of a top quality embryo rate of more than 50% in P4 patients. So all your Poseidon 4s, I told you no ICSI for all, and please do oocyte activation for Poseidon 4. Does freeze-all help? It doesn't. If you have less than 10 oocytes, if the endometrium is good, if the progesterone levels on day of HCG are fine, freeze and fresh will give you the same kind of outcome. So you can see here this wonderful study by Roque. For 1 to 3 oocytes, fresh and frozen results are the same. 5 to 9 oocytes, it's the same. 10 to 15, yes, we know the supraphysiologic levels will impair endometrial receptivity and cause a reduction in pregnancy rates with fresh transfer. Adjuvants, of course, we have enough meta-analysis now that the 3 adjuvants that really work, coenzyme Q, DHEA, and growth hormone. Of course, androgens we have all been using for years, more than 10-15 years now. It keeps going to and fro. DHEA is better, testosterone is better, which one is better? I think it's your personal choice. If you have 2 to 3 months, then DHEA is good. If you want to start a little earlier, then maybe testosterone or 20 days is also equally good. Growth hormone is being rejuvenated, but we still don't know the perfect protocol. 4 or 8 or 12, start from the luteal phase, start from day 2, until what day should you keep giving. So although there are a lot of papers showing better outcomes, we still need more data to give us the best protocols. Resveratrol, of course, we know red grape wine. Skin extract, again, seems to be a good regenerative agent. Melatonin also is coming in some way. Vitamin D supplementation. So all these are as per your personal choice, but we have scientific evidence that most of these seem to be working for regeneration and reversing some of the aging processes on the oocyte. The classic study which showed it all, the top ovary is a young ovary, the second ovary is an atrophic old ovary, menopausal. The third ovary is the same second ovary after 15 weeks of coenzyme Q. So you can see the amount of regeneration that you can expect. And here you can see with CoQ, you have a 2.2-fold higher chance of getting a better outcome. With DHEA also almost twice the better outcome is expected, growth hormone as well. So these 3 really need to be studied in more detail. Do we have some time or?
Thank you.
Because we have till
So we'll
12:30.
be-
I think this session is till 12:30. Yeah.
Now we have to
So-
go for oration. Central place.
12:30. Okay. So the future, of course, just a few slides. I think it's towards the end. Intraovarian PRP, we have been talking a lot. Of course, it's your personal skill whether you're able to do it transvaginally under ultrasound guidance. Into a small atrophic streak ovary, I find it very difficult. I prefer the laparoscopic route, injecting on both surfaces properly under the capsule of the ovary. But what evidence do we have? Of course, there are a lot of hypotheses how it works. This was the first large study, 500 women, where they did it vaginally and they showed increase in the antral follicle count, increase in the number of mature oocytes, increase in the number of blastocysts. And in the young age group, especially your Poseidon 3 with a very, very poor ovarian reserve, they showed a live birth rate of 34% with intra-ovarian PRP. This is the other big study which is just published this month, 2024. But the only difference was they said activated PRP is much better. So calcium activated PRP, your live birth rate is 33% as against 12% in the non-activated group.
Thank
And
you,
this
sir, because we're winding up.
Yeah.
How can we? We have to go to oration. No, instruction has come.
I'm extremely
I cannot
sorry.
defy the management. I cannot defy.
Fine. Anyway, that's the last
Okay, thank
slide.
you very
So,
much.
Last slide.
Yeah.
So if all fails, you have your 7 oocytes from the one donor who can donate only once in her life to one couple. And please follow all the laws. Please promote egg freezing. Fertility preservation is the next big thing. Women are not ready to accept egg donation as easily as they used to 30 years ago. And of course, these are the final ASHRAE guidelines. But my personal pre-treatment Poseidon 1 and 2, I think you just have time to take a photo of the slide. 1 and 2, judicious use of agonist, very, very important. 3 and 4, again, remember, agonist always better. And so that's it. That's what I do. 60 days of pre-treatment, coenzyme Q and whatever other favorite molecules you love. Long agonist with HMG, don't use REC FSH. Short antagonist, dual stim in the reverse way, which I told you. And fresh or frozen as per your usual parameters. And please don't listen to every add-on that comes on in the market. Oh, this is working, that is working. You have a huge duty, ethical and moral, to your patients. So please do a good scientific study, research all the papers, and then start using these molecules. Thank you so much,
Thank
ladies
you,
and
Dr.
gentlemen.
Jatin.
Thank
Big
you,
round of
Chairperson.
applause. Thank you for telling it what to do, what not to do for poor responder.